Oh, for me, no.
We warmly welcome you for yet another postgraduate clinics in general surgery. This is the third week we are experimenting the newer system for having one case, but then one case also looks quite longer because our experience has been even one case is taken for 1.5 hours. But anyway, like the discussion is quite fruitful. Maybe for another 2 more weeks, we'll be having a single case session and let us take inputs from all the faculty and the student community as well. Then we will decide about continuing either we are going to have a single case or a double case session. We warmly welcome the invited faculty, Professor Shilpa Rao ma'am. She is the head of the breast services at the Kane Hospital and St. G.S. Medical College and also serves as a professor of surgery and head of the unit. We are
Good
expecting
evening,
Dr.
sir.
Professor Pavita. Good evening, madam. Professor Pavita ma'am is the current head of the department of the Department of General Surgery at the Government Valley Medical College. I also warmly welcome our regular faculty. I could see, thank you, ma'am. Kanna sir, Srinivas sir. Good evening, ma'am. Good evening. And I could see Professor Samiranjan Naik is Professor of Surgery from GSL Medical College, Rajamandri. And Professor Ratna Chopra ma'am is from the Indira Hospital, the Northern Delhi Medical College Hospital, professor and head of the department. And I could see Professor Rao and other senior professors. Without much ado, we also warmly welcome the students who are watching us in the YouTube. Friends, we are indebted to Professor C.D. Narayanan sir for kindly permitting his department postgraduate, Dr. Dharani Priya, to present her case. Thanks, Professor C.D. Narayanan sir. And I warmly welcome Dr. Dharani to start her presentation. Faculty, please take over. Dharani, you will be allowed to take through the history without stop. You sum up the history
sir.
at that point of time. Then faculty will go back to the first slide onwards and continue. And
Okay,
then
sir.
the same thing will happen for the clinical presentation. And then they will visit the slides and take it. So the first half
Okay, sir.
of it will be history discussion and the clinical discussion. And rest of
Okay,
the
sir.
thing will be based on the sort of clinical management investigations and up till recent advances. We have an
Okay,
hour of
sir.
time for this case for discussion.
Okay, sir.
And should you wish to add up something or should you have a problem, please tell so. The faculty here will be able to educate you and they'll be
Okay,
able to
sir.
bridge up if you have any issue. Thank you very
Okay,
much
sir.
and wish you a good luck, Dr. Dharni. All the best.
Thank you, sir. Thank you,
You
sir.
can start sharing the
Can I share my
PowerPoint.
screen?
And yes, please. Yes.
Okay, sir.
Faculty, please take over.
Is my screen visible, sir?
Perfect, ma. Perfect. Good to
Yes.
go. All the best.
Okay. Good evening to all the faculty present. I'm Dr. Dharni Priya, junior resident from Ramachandra Medical College, Chennai. I'm here to present a case of breast lump. My patient is a 53-year-old post-menopausal female homemaker who came with complaints of lump in the right breast for the last 6 months. The patient was asymptomatic 6 months ago, after which she incidentally noticed a lump in the right breast. It was insidious in onset and initially small in size and progressed to attain the current size. It is not associated with pain and there is no history of any nipple discharge or nipple retraction. There's no history of skin ulceration, no history of lump in the contralateral breast, and no history of fever, loss of weight, or loss of appetite. There's no history of back pain, headache, seizures, abdominal distension, jaundice, or breathing difficulty. And there's no history of trauma to the breast. Past history, the patient has no known comorbidities and has no previous history of breast lump. The only surgical history that the patient has is an open sterilization done in 1991. Menstrual history, the patient attained menarche at the age of 12 years and menopause at the age of 46. The patient had regular cycles, and during her first childbirth, she was 19 years of age, and second childbirth was at 21 years of age. Both her children were normal vaginal deliveries, and each of them was breastfed till the age of 1.5 years. Personal history, the patient has no history of smoking or any alcohol consumption. She has a normal mixed diet and appetite. There's no history of OCP intake or no history of hormone replacement therapy, and there's no history of any radiation exposure. Family history, the mother had carcinoma breast at 65 years of age, for which she was not treated. There's no other history of breast, ovarian, pancreatic, or colorectal malignancy in the family. So to summarize my history, the patient is a 53-year-old postmenopausal female who came with complaints of lump in the right breast for the last 6 months, not associated with any pain or nipple retraction. The only significant family history is that the mother had carcinoma breast at 65 years of age. The patient has no comorbidities or no other past significant surgical history.
Hello.
Yes,
Hello.
sir.
Why you ask
Yes, sir.
history of radiation exposure in this case?
Sir, as it might be a cause for any malignancy. For maybe if she developed radiation for
Which
if she
radiation
received radiation.
induced malignancies? For breast case,
Yes, sir.
whether it is
Yes, sir.
necessary
No, sir.
to add.
It's more significant for thyroid. Yes, sir. No, it's more significant in thyroid and not significant in breast.
To include in a parathyroid surgery.
Yes, sir.
Which malignancy occurs after radiation?
In breast, sir.
So that is papillary carcinoma of thyroid.
Yes, sir. Yes, sir. It's not. Yes, sir. Yes, sir. Yes, sir. Papillary C of thyroid, yes, sir, but not in breast.
Okay, go to the first slide, please.
Yes, sir.
So any positive points in this history?
No, sir. No, sir. No positive except lump for the past 6 months. No other significant history, sir.
Other than lump, there is no positive history.
Yes, sir.
What is the difference between lump and mass?
Sir, a lump is, we usually use the word, Sorry, sir, I thought
Hello.
somebody was interrupting. So sir, somebody was interrupting. So we usually use the term mass for cavities like the abdomen. We usually use terms like lump when we're examining the breast.
Okay. In our time, they used to ask some terminology definitions. For example, lump, mass. So
Okay,
we prepare with all these points. Because
okay, sir.
these are very important points in your presentation. What is lump? What is mass? What is ulcer? They may ask you.
Okay, sir.
Okay. Any
Okay, sir.
positive points? Why you ask history of
No.
nipple discharge?
So to rule out if suppose she had bloody discharge, it could be a papilloma. If she had any pus discharge, if the lump
So
could
tell
be
me
an
what are different
abscess.
types of nipple discharges? What are different types of nipple discharges?
Sir, if she had any pus discharge, it could be an abscess. If she had any bloody discharge, it could be due to a papilloma. If she had any milk discharge, it could be due to, unlikely at this
Madam,
age, but
bloody
in a
discharge
younger
is
female,
again
it could be.
classified into, madam, this is
Yes,
for
sir. Yes, sir.
undergraduate level or postgraduate level.
Yes, sir.
Answer should be like this. Bloody discharge
Yes, sir.
in case of fresh blood in case of duct papilloma, altered blood in
Okay.
case of the malignancy. So they will ask
Okay.
why there is altered blood in case of malignancy? Because due to growth there is a stagnation and that lead to the alteration in the color of the. Okay. Any other type of blood? Any other type of discharge?
Greenish discharge in case of ductectasia. If there's
What
any
is meaning of
galactocele, it could be
ductectasia? What is meaning of ductectasia?
so dilatation of the lactiferous duct.
Any significance with this present case?
Ductectasia, no, sir.
Okay.
Can you define a clinically suspicious nipple discharge? What is a clinically suspicious nipple discharge?
If the nipple discharge is spontaneous and if it's not by expressing and if the undergarments are getting wet by the discharge and yeah, I think that's
so spontaneous, unilateral. Spontaneous, unilateral from a single duct, serous or bloody. All these will be suspicious of malignancy.
Malignancy.
Yeah.
Yes.
Please continue, sir.
Dharini?
Yes, ma'am.
Yeah. So
there is no history of lump in a contralateral breast.
Yes, sir. There's no history of lump in the contralateral breast.
So, which conditions are bilateral pertaining to the breast? Which pathology are bilateral?
So lobular carcinoma in situ can be, it has a higher chance of being bilateral. It has a higher chance of being bilateral, sir.
What is meaning of multifocal and multicentric?
Multicentric is when it is there are lumps present in two different quadrants of the breast. Multifocal is when within the same quadrant there are multiple lumps present.
Okay, may I butt in a little bit and ask a couple of questions? So the first thing is you talked about nipple retraction.
Yes, ma'am.
So can you define the difference between a retraction and an inversion? And what kind of specific retraction do you see in a patient in whom you're suspecting a malignancy?
Usually in nipple inversion, if you press on either side of the nipple, there's a chance of the nipple everting. But in nipple retraction, it's not possible to, it will not be possible to manually evert the nipple.
Is it, so what's the difference between malignant nipple retraction and non-malignant nipple retractions?
Malignant nipple retraction is usually due to the involvement of the lactiferous ducts. There is fibrosis and it causes...
How would you know? Like, would she give any specific history or even otherwise? Is there any specific difference? Does the entire
differentiating point between these two?
Does the nipple get retracted in its whole area, or is it like it's a kind of distracted nipple retraction? Okay, so it is usually, it's just a point. It's not the entire nipple that gets retracted. Okay, it's a part which gets. Now, the second thing I also wanted to, this thing was, ma'am defined, the breast discharge very, very succinctly. And lobular, yes, will produce bilateral. But again, novellas most times may not produce nipple discharges, but we are seeing more and more of bilateral IDCs happening today. Okay, so it should not rule out a malignancy. You should look even more particularly into the opposite breast when you're talking about nipple discharges. Yeah. So that much on this slide. If we can move on to the next slide, then they can again take over.
Okay.
Hello.
So 1 second. In the previous slide, you asked for the back pain, headache, seizure. For what? For?
Ma'am, for metastasis, I wanted to know if there's any
common site of metastasis in cancer breast.
Liver.
What is the common
liver
site
and bone.
of metastasis?
Bone and liver, ma'am.
No. Usually it is
Dharini, would it depend on what kind of IDC it is, which will point you to asking, specific histories? Any specific kind of IDCs which will have classically certain kinds of metastasis?
Ma'am, you're asking depending upon the specific type of breast CA to what it metastasis.
Yeah, the specific type of IDC, not breast CA. Like, depending on the IHC, would it kind of, certain IHCs would have certain types of metastasis? Are you aware of that?
No, ma'am, I'm not.
Like if it's an ER, PR positive,
PR positive.
What kind of metastasis? In a triple negative, what kind of metastasis? In a patient who is only HER2 positive, what kind of metastasis?
Ma'am, I'll read about it, ma'am. I'm not aware of it. I'll read about it.
Okay. All right.
Hello, Dharani Priya.
Ma'am, I think yes, sir.
Okay, you want to answer?
No, I was saying, sir, metastasis to the lung, more common.
Pleural effusion is more common.
Yes,
as
pleural
I am
effusion.
told, it depends upon the IHC markers.
Okay.
That is luminal A or luminal B.
B.
Proceed to the next.
Your pattern of slide, you could have changed it, doctor. The no history of trauma can come a bit earlier.
Okay, sir.
And fever,
And metastasis
loss
of
of
last
weight,
history.
fever, loss of weight is not that common, but you can bring it later.
Interest.
And
sir.
no history of back pain. Okay, that's fine. No history of then breathing difficulty would come next. Then jaundice, abdominal distension, headache, seizure. How many of your breast cancers?
No, sir.
Metastasis to the brain. Have you seen the case?
Yes. No, sir.
Case have you been taught? How many cases have you been seeing?
No, sir. I've not seen any cases.
If at all you have a metastasis, you will go in for a early morning frontal headache. Okay.
Okay, sir.
So the history wise, when you put the slide also, give importance according to the chronological order which can occur. Because back pain.
Okay, sir.
Back pain, where do you get actually?
The metastasis is usually to the thoracolumbar spine.
Lumbar.
So maybe lower back pain. Yes, sir.
Jaundice or breathing difficulty. Why that one? So breathing difficulty should come first.
Yes, sir.
So that could be in the chronological order then. Before finishing up this breast, you went to no history of lump in the contralateral breast.
Okay, sir.
So I think Professor Shilpara madam and Bhavita madam will agree with me.
Yes, sir. I was just trying to finish off all the history about the breast and then move on to the other areas. But it's okay. Yes, sir. I'll change it next time.
So Dharini, normally what we kind of ask our students is, you start with the history of the origin, duration, progress of the lump. Then you go into the complications which are local. Then you go into the complications which are systemic. And then you go on to the etiology of the breast lump. And then you go on to the rest of the histories. That's a standard format that we follow for any history taking. That's what sir is trying to say.
Yes,
and into a few, into better, maybe a couple of more slides, so it becomes more effective in terms of presentation.
Okay, ma'am.
Yes.
So what are the causes of breast? What are the causes of breast ulceration in a patient of breast lump?
Either it can, if it's malignancy, it could be due to infiltration of the skin. It could cause ulceration, or in cases where there is a large fibroadenoma, sometimes the lump will be pressing and causing atrophy of the skin. So in those cases also, it could cause an ulceration.
Enfilodes tumor. Is there any clinical way of differentiating between the two? Ulceration in a benign lump and ulceration in a malignant lump.
In a benign lump, if you try to probe between the skin and the lump, you will be able to probe.
Probe test is there.
You can straight away say no history of any skin changes. That would be better.
Yes, sir.
Because you will have some either a dimpling, puckering, then you'll have some skin edema, then going for ulceration. Straight away, no history. We can say simply no history of any skin changes. That will simplify. That will simplify. There is no skin involvement.
Yeah, because there are so many skin changes. I mean, nowadays with the TNBCs, you're seeing so many satellite nodules happening. So, just ulceration is kind of like a red herring, and it can just take you everywhere else. So, if you just say that the skin is uninvolved, then if somebody wants to ask you the different types, they will ask you. But if you're writing skin ulceration, you're asking for trouble, really.
Okay, ma'am. I see.
And here you've mentioned that she's not. Here you've mentioned that she's noticed a lump in the right breast. We're not able to make out from your history exactly in which part, of the breast, and unless and until I have missed out, have you mentioned the size of the lump to begin with and what it is now?
No, ma'am, I thought we'd mentioned the size only in examination. I've not mentioned the size. I've just said that it's small. I just said that it's small.
Of a lemon or size of gooseberry, like that.
It's good to mention that roughly
how it noticed like that.
Yeah.
Okay, ma'am. That's right.
He
said it's almost doubled in size. Yes, sir.
Two points.
Yes, sir.
One more point you missed is the recent retraction of nipple is clinically significant. That's what madam is expecting from you. Don't do such mistakes in your PG exam. And one more important point is this is commonly asked full question, and in Viva also they will ask what are the cutaneous manifestation of the CA breast.
Cutaneous manifestations.
All these points just now we discussed. All these points are required.
Yes, sir. Pure orange, ulceration, and satellite nodules. Yes, sir.
Okay, proceed.
Okay, sir. Okay,
sir. Dharini, just one more thing. Again, like ma'am mentioned, we used to talk about lemons and gooseberries, but there are a group of examiners who can be very sarcastic, and say that lemons in Kerala are very different in size from lemons in the north. Yes. So I think it's not, so you say you either use tennis balls or you just say approximately.
I just specific and I'll mention the size.
Yeah, she would show you that it's about 3 centimeters to begin with, and now it's like, she'll show you with her hand or whatever. So you say approximately, very obviously on history. Okay, so just mention in centimeters the approximate size when she noticed and the approximate size when she has come to you.
Okay.
All right? Yeah.
Okay.
Why did you add the trauma?
So if there's any traumatic fat necrosis, it was a history of completion. It's not a recent lump, it's a lump for 6 months. But for completion's sake, I added it.
How long
if she could have had any traumatic fat necrosis.
What does it form to? What does it lead on to?
So two things. Either the lump could be for traumatic fat necrosis, or because of the trauma, the patient could have incidentally identified the lump. So for one of these two causes, we usually ask for trauma.
One is it draws the attention of the patient to the lump, pre-existing lump. And number one, two is after history of trauma, patient develops a hard lump.
Yes, sir.
Which mimics malignancy.
So at what age is traumatic fat necrosis more common? And why?
Ma'am, I think traumatic fat necrosis is more common in elderly because it is in their breast where it's more fatty and it has less. It's common in elderly, ma'am.
Yeah, so it's common after 60 usually because the breasts kind of convert from the fibroglandular tissue into
tissue to fatty tissue,
and everything kind of there's a lot more space to kind of get that necrosis, and which is why mostly when women over the age of 60-65 it should be a differential diagnosis if there is a positive history of trauma. This lady is a little on the borderline, but yes, you can mention it, but you should know the reason why you're asking it. Yeah, and like sir said, very commonly the trauma, there may be insignificant trauma which actually draws the patient's attention to the lump. So those are the two things that can be understood by asking that question, right? I think we can move on to the next slide, otherwise we'll be here only. Go on to your next slide, Bacha.
She has no past significant, she has no comorbidities or no previous history of breast lump.
So what is the previous breast lumps which are significant in breast cancer?
Ma'am, she could have had any history of atypical ductal hyperplasia or florid hyperplasia or any carcinoma. Yeah, these two, I think, are significant history. Many benign lumps that could progress to malignancy if she's had them removed.
Yeah, or even surgery. Just basically doing surgery also. So no history of any lump or any surgery on the breast for whatever reasons.
No. Yes,
right?
ma'am.
Okay.
Yes,
can we move on to the next one?
Yes, ma'am. She attained menarche at 12 years of age and menopause at 46. And she had 2 children, normal vaginal delivery, and each of them was breastfed for 1.5 years.
So again, breastfeeding is something everybody likes to ask upon. How is it important for the mother and how is it important for the child in terms of pathological disease?
Ma'am, I think it decreases the estrogen exposure time. So the longer she breastfeeds, it's better for the child also in terms of nutrition. For the mother, in terms of CA breast,
No,
I think
that's
it
why I
decreases.
specifically said pathologically, how does it improve? There are a lot of psychological, effects, but pathologically, how does it affect the mother and how does it affect the child?
Pathologically, as the mother, I think it causes decreased estrogen exposure at the time when she's breastfeeding.
Okay, and the child?
And it might be protective.
The child?
The child, ma'am, for nutrition.
No.
For nutrition purposes.
Pathology. So now there are recent papers which have come out which says that the child gets protected from acute lymphoid ALL, acute lymphoid leukemias for the first decade of their lives. So they did a large cohort of study and they found that in children who have been breastfed for more than 9 months, there's a significant difference in the incidence of ALL which happens in children up to the age of 10 years. So that data is also coming up. So it's protective for both the mother and the child.
Okay, ma'am.
Right?
Yes, sir.
Yeah. And
what are the risk factors you expect in the menstrual history?
In the menstrual history, ma'am, if the patient has had early menarche, as in like before 12 years or late menopause, there's a increased estrogen exposure. If the patient is...
What do you mean by late menopause?
Ma'am, more than 50 years of age. 45 is the normal age. Anything more than 45?
No. It's more than 55. Nowadays,
more than 55.
More than 55 is... do you ask for regular cycles? Regular cycles?
I ask for regular.
You have written regular cycles?
Yes, ma'am, I've written regular cycles.
Why you want to ask for that?
Ma'am, to rule out any history of PCOD or anything. Nothing else.
If we related to your case, if it is an irregular cycles, they would have, without her knowledge or without her understanding, she would have taken some hormone replacement pills or
hormone replacement
pills.
Okay.
And what
Dari
is the
also
first age at first childbirth?
Ma'am?
Age at first
the
childbirth.
earlier it is, yes. Ma'am, the earlier the duration between menarche and the first childbirth, the earlier the childbirth, it's supposed to be more protective. Women who have children over 35, it's shown that there's increased chance of...
Has increased risk.
They
have a relative risk of 2 getting a malignancy.
Yes, ma'am.
Is it your normal vaginal delivery have any role?
No, ma'am.
No need to write which is not important to that particular patient.
Yes.
Yeah. What about, would you like to mention abortions in this patient? Is it significant?
Abortion history.
And also whether the children were conceived naturally,
natural,
or
yes,
whether
ma'am,
there
yes.
was assisted, reproduction.
Reproductive techniques. Yes, ma'am, because that all, it all
So
shows, yes, ma'am,
both
estrogen
those
exposure.
points are very important. So tell me why
Yes,
abortion is an important factor in history taking.
Abortion is again important because it shows another conception. So there is, it shows a certain significance of time of estrogen non-exposure. So that is significant.
Yeah, so multiple abortions can enhance. It's not estrogen, it's more of progesterone happens later. So unsustained or prolonged estrogen exposure, multiple abortions, chances are that, the lady could have an increased risk of breast cancer. And IVF is again an important point that you need to add, that they were both conceived naturally.
Spontaneously conceived. Yes,
yeah, so all that, that would complete the entire personal and menstrual history.
Yes, ma'am.
Yeah.
I move on to the next slide, ma'am.
Yeah. Also, since you're talking about children, how many children is protective? Because if you go by the fact that, having children protects breast cancer, then India's population has already gone beyond of control. So what is the statistical significance in number of children and its protection towards breast cancer?
I'm not aware of the statistical significance.
Up to 3 is also okay. Yeah, 2 to 3. After that, the protection is lost completely.
Oh,
right. Okay. So so you have to say, you can't just say that, okay, have kids and you get protected. So you have to be informed that after 2 or 3 children, there is no protection.
Okay.
No added protection at all. All right.
Okay.
Yeah. Move on to the next slide.
The patient has no history of smoking or alcohol, normal diet, no history of OCP intake or hormone replacement therapy.
So your OCP and hormone replacement should have come in the previous slide.
In menstrual history, ma'am.
Yeah, it should have come there, right?
Okay. Okay. Thank you for that.
Yeah. So everybody is going to talk about the mother having breast cancer at 65.
Yes,
tell us how does that translate into the daughter and the subsequent risk in the rest of the generations?
We're looking at if it could be a case of familial or hereditary malignancy, and if the patient
65,
might have BRCA.
At 65,
yes, ma'am. Yes, ma'am. At 65, it's a higher chance. There's a higher risk that there's a higher chance that it could be sporadic breast CA. But the reason we ask for family history is that if to look for BRCA1 mutations, BRCA1, BRCA2 mutations, if it could be familial or hereditary malignancy.
She's also 53, right? She's
53. Yes, ma'am. Yeah, she's 53.
So which BRCA mutations will produce malignancy at 53?
BRCA1, ma'am.
BRCA1 is more aggressive, no? It produces it much earlier. So actually, this looks like it's more sporadic. How much percentage of breast cancer is actually familial?
Very less. It's more it's known to be more sporadic than
you can't give me random answers. You have to give me statistics, right?
Yes, ma'am.
So history of breast cancer in
less than
family.
30%. 30% is known to be
no. That's too high, bacha. 10%. 10% of familial and 10% of history of cancer in the family. They're two different entities, but it's not more than that. So most times, if you look at it, it would still be sporadic, especially if it's in the 6th and 7th decade of life, more likely to be sporadic.
Yes.
Yeah. Yeah.
Yes.
What is the most common type of cancer in BRCA1 mutation?
Most common type of mutation.
regarding IHC?
Luminal BRCA1 mutation, ma'am.
Yes.
BRCA1 mutation is luminal to ER, PR. It could be positive or negative, and Ki67 is increased.
Usually it is triple negative breast cancer. Usually it is triple negative breast cancer.
Okay.
They are
And
more
here,
aggressive, they are more younger, they are more triple negative, and they have, you know, so all of that, they're very, very aggressive, and they can be bilateral.
Okay.
You know, and they can, so that's why, those are very, very aggressive cancers. So all those things you have to mention: bilaterality, TNBCs, like ma'am said, aggressive cancers, right? All of that will happen.
Okay.
You have mentioned history of breast, ovarian, pancreatic, colorectal, which is more significant.
Ovarian is more significant, ma'am. Ovarian and
Ovarian is more significant.
Ovarian is more significant.
Will paternal auntie has an CA breast, will it be transmitted to the female? Only maternal or paternal?
No, ma'am, paternal, the father sisters or the paternal aunt can also be transmitted.
Oh.
What are the types of mutations that you look for, and why are they important?
Ma'am, we look at BRCA1, BRCA2 mutations, P53 mutation, like Leishmania.
So they may be somatic, they may be line mutations. And the importance is that whether there are HER2 mutations, BRCA1, BRCA2, or others, the importance is the targeted therapy for all of them will be different thereafter. So here comes the importance of looking for them.
Is there a new one, BRCA3, madam?
Yes, it's coming up. BRCA3
Yeah,
is also
I
coming up.
remember you telling me, but asking me to find out.
Yeah, and I think in another 5 years we'll have 4, 5, 6 also. So, what are the other things that are, that are recently coming up, Dharani, in terms of they've figured out certain genes make you resistant to cancers, and certain genes are other than the ones you mentioned. Are there anything else that you know?
Something that makes us resistant. Yes, something that makes us resistant to cancer.
Any other genes which are coming up because in breast cancer every day there's something new that's coming up, right? So
Yes,
is there something that's now happening where certain genes have been whose action or inaction makes them immune, so it makes you immune to breast cancer?
No, ma'am, I'm not aware. I'll read up on it.
So the RAS and ONG genes, no, our job is to tell you the answers. Yes, that's what Dr. Kanagavel has directed us to do. So the cyclins, the C and D, the D and E cyclins. Okay, so overexpression is known to kind of cause the proliferation from G1 to the S phase, right? And they found an experiment in rats where they express the cyclin D, and they found that they were completely resistant to cancers. So now they're working on therapy which works on the growth cycles, which is coming up. Okay, so there are newer and newer things which are coming up in terms of what we can target and not target. But this is like one of the things that they are now exploring in terms of cancer immunity.
Okay, ma'am. Yes, ma'am.
Yeah. You can go to the next slide.
Yes, ma'am. Goes to examination. Shall I start with examination, ma'am?
Proceed.
Can I continue presenting? Yeah. The patient is conscious, oriented, and cooperative. The patient is well built and well nourished, and all the vitals are stable. There's no history of paralytic cyanosis, clubbing, or pedal edema. Moving on to the local examination of the breast.
Wait. Go back. We've not finished with that slide. So when you talk about well built and well nourished, it tells me nothing at all. Right?
Okay. Okay.
So what are you looking at?
I'm asking, like, if you want me to specify about the BMI or anything, or do you want me to say why I'm asking for well-built and well-nourished?
Yeah, not just BMI. Actually, BMI is not really a great indicator. What else is a better indicator in breast cancer?
If the patient is obese, there's a higher chance of like having dense breast, so it might be a risk factor for malignancy. Weight is maybe important.
No. So BMI being high and obesity being high, you have what is today known as sarcopenic obesity, which is a very wrong indicator for breast cancer. So there are better ratios that we look at today, which have more significance than BMI. Are you aware of that? It's a very simple thing that you need to do. So it's the waist-hip ratio.
Okay.
Right. So that, and you should mention that when you're talking about just being well nourished and built is a pointless sentence. You have to mention the BMI, the waist-hip ratio. Yeah, all those things have to be mentioned in this.
Okay.
Continue.
Local examination of the breast. The patient was examined in a sitting position with arms by the side, arms raised above, and arms pressing and relaxing over the hips on leaning forward position and the supine position. There was a fullness noted in the upper outer quadrant of the right breast, and both the nipples are found to be at the same level. There's no nipple retraction noted, and the nipple areolar complex is normal. There's no fullness noted in the axilla or the supraclavicular region. There's no scars or dilated veins noted. No dimpling, tethering, or pearly orange is noted. And the contralateral breast and axilla appears to be normal.
Again, here, Dhadini, ma'am, just one comment before you take over. Like sir had said, here also, your inspection, the findings are all haywire. You start with the breast, you finish the breast, then you go to the axilla and wherever else. You're going to the breast, then you're going to the axilla, then you're going to the nipple areola, then, so maintain an order in your local exam also.
So, order of examination is very important.
Yes,
sir. Yes, sir.
This is very
Yes, ma'am,
Yes,
please take over.
And that in which position these findings, and when you altering that, like sitting the position with arms by the side or arms raised above, you have to mention it differently, because the level of the nipple may change when you raise your arms above the
raise arms above there. Yes, sir.
Then you have to mention it in each position. What was the findings? Whether there was any difference in the findings.
Okay.
And you have mentioned everything as a single line, no tethering or PUDRH. Don't like that. You write region, no tethering, no PUDRH, nothing like that. Your nipple retraction, no nipple retraction, noted, and no fullness. You are jumping nipple retraction, breast, and everything. As ma'am told, you are jumping everything. The slide is jumbled on.
Okay.
You also need to mention the submammary fold.
Yes,
it's getting to be more and more important now with breast conservations happening. And if you really want to go beyond of that, you should mention the general volume of the lump to the breast size.
And
whether it's occupying 20%, 30% of the breast volume, 40% of the breast volume. Again, very important because it will tell you the further management of the patient.
Okay.
Yeah.
And why you want to examine on inspection, arms pressing and relaxing over the hip on inspection? What finding?
Just to see if the lump becomes more prominent. That's it. Nothing.
It always will become more prominent.
Okay.
This arms pressing and relaxing over the hips only on palpation, not on inspection. Breast is already a subcutaneous structure. It becomes more prominent only. It is superficial to pectoralis major.
Okay.
What is the importance of nipple deviation?
Retraction, ma'am.
No, nipple deviation. You have talked about retraction. You've said nipple areolar complex is normal. I want to know about nipple deviation.
If it's a large lump, then there's a chance that the nipple might be deviated towards the side of the
It's
lump.
not about a large lump. In malignant cases, nipple will be deviated towards the lump, while in a benign lump, it will be deviated away from the lump. So you have to talk about position, shape, deviation, and even any ulceration or change in color of the nipple. And if there is any discharge that you can see on it.
Okay.
Yeah. Please move on.
Doctor, do you know the 7 Ds of nipple that changes? It was given
7
in a book
Ds.
called, there is Norman Browse, that book gave you 7 Ds. You can note it down. I'll tell you in alphabetical order. Depression, destruction, deviation, discharge, discoloration, displacement, and duplication. These are the 7 changes which can occur in a nipple.
I should also write this down, sir.
Madam, I send it to madam. This is a very old book, madam.
No, I know. But it's a nice this thing, and you will not forget anything at all if you kind of remember certain.
You send it in alphabetical order: depression, destruction, deviation, discharge, discoloration, displacement.
Yeah. Very nice.
And duplication. That book is Norman Browse, madam, Clinical Methods.
Yeah. No. I was just joking. All right.
Thank you, madam. Thank you for the great words. So displacement means, there's a benign lump which will displace the nipple to the opposite side. Even if it's a malignant lump, early cases, there'll be some sort of displacement. But once there's infiltration, you will get a nipple retraction. Okay.
Okay, sir.
So when you've described the regional examination of breast, you've started from the involved breast right away. It may be a good idea to present like this, that whether there was bilateral symmetry of the breast or not. And that if it was not, if there was no symmetry, you talk about asymmetry with respect to size, shape, and contour. Right? And make a mention of which breast appears normal, and that I'll be describing the other breast now first.
Okay. I shall start with the unaffected breast and then move on to the affected breast.
At least make a mention that which breast is apparently looking normal, and that which breast are you describing, right? And talk about any asymmetry with respect to size, shape, and contour.
Okay.
Yeah. Please
move on to the next slide.
Yeah.
Okay. On palpation, there's no localized warmth or tenderness. A lump of size 6 × 5 centimeters is palpated in the right upper quadrant, and it occupies from the 9 to 12 o'clock position. It's hard in consistency. It has well-defined margins and irregular surface. The lump moves with the breast tissue. There's no puckering or tethering on moving the lump, and there's no nipple retraction or nipple discharge. There's no involvement of chest wall, skin, or underlying muscle.
What is puckering? What is tethering?
Tethering, if there's an involvement of the Cooper's ligament, you can see that there's a dimpling of the skin, as it's so that is called as puckering or tethering.
What about purity orange?
Purity orange is if there's blockage of subdermal lymphatics, you can see that the skin becomes like an orange peel. There's edema of the skin, and that is called as purity orange.
I think you have not prepared the slide with sincerity. There is a lot of spelling mistakes. Written no localized warmth. The history itself you have written insidious in onset, spelling wrong. I thought that is this one, but here also there was a spelling mistake. What do you mean by well-defined margin on irregular surface? Will a malignancy well-defined margins or?
No, ma'am, it's more towards ill-defined margins, but in this patient, the margins were well defined.
Margins are very well defined.
Yes, ma'am.
How will you test?
Dharini, you want to talk. So, like Dr. Chopra said, you have to mention the opposite breast, but even in the same breast, before you actually go to the lump, you need to palpate the entire breast. You can't just hit the lump straight away. You have to go through the, you have to go from the normal to the abnormal always. So if you have
Yes, ma'am.
then the normal breast first, and before you palpate the lump, you actually palpate the rest of the breast to see if there's any other abnormalities in the rest of the breast before you actually come to the lump. Right?
On palpation, that's how I did it. But I thought on presenting, I have to start from the affected breast and then move on, because in the end I mentioned that
Which is exactly why
it
we're
was
having this conversation, that you should mention the opposite breast first.
opposite breast
You must
first.
mention all the normal quadrants of the breast before you go to the affected quadrant.
Okay.
Right?
Yeah, very important, because this may not be the only lump in the breast. You haven't mentioned anywhere that there is no other lump palpable in the same breast also.
Yeah.
Okay.
That's why
Priya.
ma'am is saying this. Yeah.
Okay.
And just a
Priya.
point on your
Yes, sir.
instruction, just because
Yes, sir.
when you complete, you must also talk about whether both the arms are of the same dimensions. Because on palpation you would actually go and measure it, but whether there is any gross discrepancy between the two arms. And why would you ask that?
To look for any lymphedema.
Yeah,
If
and
the arms are
it happens very often. So that's just to it completes the fact that you are aware of what's
examined
happening.
fully.
Yeah.
Yes, ma'am. Okay. Yes, ma'am.
Priya,
Yes, sir.
how to test fixity of the lump to the breast tissue?
Fixity of the lump to the breast tissue.
The breast tissue.
So
How
you
to
try.
demonstrate it?
So you move the lump along with the breast tissue.
Yeah, how to demonstrate it?
Right. You hold the breast
Simple
with one
question.
hand, sir.
Simple
Right?
question.
Yeah, you hold the breast with one hand. You hold the lump with the other hand. You try first moving it
You have to
parallelly.
hold the quadrant of breast with one hand. And you have to
Yes, sir. With one hand.
Hmm?
Yes, sir.
And how to test
And
the
the lump with
fixity
the
of
other
the lump to the muscle or fascia?
So muscle, you ask the patient to keep the hands on the hips, and you ask them to press on the hips. If the anterior axillary fold is taut, and then you can hold the lump and move it parallelly and at right angles.
Which muscle you are testing?
Pec major, ma'am. Pectoralis major, ma'am.
Yeah, be full form. Pectoralis major. Don't say pec major. Please.
Yes, sir.
Okay.
Yes, sir. Pectoralis major.
Just correction. Pectoralis major.
Yes, sir.
When do you say it's fixated to pectoralis major?
So if there's restriction of mobility of the lump on contracting the hips.
Along the line of the fibers or across the line of the fibers?
Along the line and across the line. Correct.
So you should know where the pec major is.
Yes.
Where is the pec major inserted?
Sir, along from the lateral border of the sternum to the acromion joint.
Where is it inserted? Lady between two majors.
Two majors. Yes, sir.
Where?
Lady between two majors, sir.
The humerus.
Bicipital groove of the humerus.
Yes, sir, of the humerus.
Teres major and latissimus dorsi.
Dot.
You have to move along the fibers and look for fixity.
Yes, sir.
Make it taut. Feel for the anterior axillary fold. It is taut. Then you move and see.
Yes, sir.
Okay.
Yes, sir.
Fixity to pectoralis major is not fixity to chest wall. Underline those words.
Yes, sir. Yes, sir. Yes,
fixity to pectoralis major is not fixity to chest wall.
Chest wall.
That's
yes,
what.
Sir.
And you said purity orange. What is purity orange? Due to?
Purity orange, I said, if the subdermal lymphatics are obstructed, there will be an edema and the orange peel appearance.
Yeah, there are three
of the skin.
Three components. One is involvement of the subdermal lymphatics. One,
Yes,
indrawing of the hair follicles. So
All
what
hair
happens? It gives you the orange peel appearance.
Orange
And
peel
there is
appearance.
fibrosis around the subdermal lymphatic. That is why when you feel that hard in consistency. So fibrosis, indrawing of the hair follicles, and involvement of the subdermal lymphatics.
Yes, sir.
So your patient has got a body orange, a patient has got a dimpling and puckering.
Yes, sir.
Which do you take it as a malignant feature?
One
of the famous question asked by one of the famous faculty who is here. Professor Ajay Khanna's
the orange is taken as a sign of
dimpling, puckering or tethering is a classical feature of malignancy, whereas body orange can occur even in breast abscess or in even chronic mastitis. Okay.
Okay, sir.
If you see two of these things, which do you think could be more in favor of malignancy? Both can be, but tricky questions asked. Okay.
Okay, sir.
Please, ma'am.
I think you can go on to your next slide.
Okay. On examining the right axilla, a single 2x1 centimeter firm mobile lymph node was present in the central group. There was no other palpable lymph nodes, and the supraclavicular region appears normal with no palpable nodes. The contralateral breast, axilla, and the supraclavicular region appear normal.
Normally, what will be the consistency of the axillary lymph node in case of cancer breast?
It could be hard, ma'am. Ma'am, I found it to be firm. The lump was hard, but axillary node was found to be firm. So
and you have written
go with my
the central group of lymph node is palpable. That to
yes, ma'am.
Are you able to surely palpate?
Yes, ma'am. I was able to palpate. I palpated along the chest wall. On comparison chest wall, I was able to palpate the lymph node.
Against the chest wall?
Yes, ma'am. Against the lateral chest wall.
Are you looking for?
Sorry, ma'am. I was not able to hear you.
Are you finished it enough, or are you doing it? Sorry?
What is the importance of looking at the infraclavicular?
Sorry, ma'am, you're not audible. I didn't get your question.
Wait. Madam is asking. Please wait.
So what is the importance of examining the infraclavicular area?
The infraclavicular area?
Yeah.
Ma'am, to look for nodes, infraclavicular nodes, it will change to the staging also.
Yeah, so you must make a mention of that. What is the clinical evidence of presence of abnormal lymph nodes there?
In the infraclavicular region, it comes under level 3 nodes, ma'am. Apical nodes.
No. How do you clinically say that they are palpable or not? So normally there is a hollow in that area. If you find a fullness,
press it up against it.
Yeah, if you find fullness, or if you find that there are prominent veins. Prominent veins are also an indirect marker of presence of level 3 lymph nodes. Yeah.
Can we also percuss and see if there's a if there's a dullness present, one, or is that only theoretical?
Internal mammary very rarely found.
Okay.
But yes, it is mentioned in the books.
Okay.
We can move to the next slide.
Okay.
The infraclavicular is level 3. It is behind the Halstead's ligament. You know what is Halstead's ligament? Costoclavicular ligament.
Costoclavicular ligament.
Usually when it is enlarged, you will not be able to palpate. As madam said, there will be some fullness and internal mammary nodes. Even if you are enlarged, you will not be able to feel. Only you have to percuss. Where do you percuss and which spaces to look for?
To percuss the infraclavicular nodes, sir?
No, for the mammary nodes.
Mammary nodes, ideally from 2nd to 6th rib space.
Okay, answer madam's question.
Yes, ma'am.
So Dharini,
can I continue with? Yes, ma'am.
No.
Yes, ma'am.
You said central group of lymph nodes. The whole concept of breast surgery and sentinel nodes and everything follows the the theory that there are no skip lesions in the breast. So when would you have this except if it's central, it's already gone up, right? So
yes, ma'am, it should have gone.
So how do you explain that?
There might be micrometastasis to the anterior axillary lymph node, which is not clinically not palpable.
Can you show the picture of the patient?
I thought I was not supposed to because of YouTube will remove it. That's why I swiped past the first one.
Now take it off, please.
Yes, yes.
Yeah, so basically what it does is it tells you that it may not be possible to do a sentinel node on this lady, if at all later on you're planning to do that. Okay, so it gives you an indicator that the level is beyond the sentinel node level. So when you're talking about treatment protocols, and when we come to that, this would be a contraindication to do a sentinel map or an axillary mapping, right?
Mapping, yes.
Yeah, go on. Well, I think we should
moving
skip this and go on to the next.
But while seeing the picture, it doesn't like central lymph node. There is a fullness which is obviously seen, no?
It was no, ma'am. That was not in the axilla. She had an parafat or that was not for the lymph node, ma'am. It is. It looks more like maybe an axillary breast or just an axillary parafat. That's all. It was not a fullness.
You are telling
Yes, but it was. Yes, but not
never accessory breast. You're putting yourself into very dangerous waters. It's just hypertrophic, the tail of Spence. Yes. Accessory breast is a completely different ball game. You don't want to enter there. Okay, so all you say is probably it's axillary fat or it's an hypertrophic tail of Spence, never an accessory.
Okay. Should I continue with the systemic examination now?
No signs of pleural effusion.
No, sir. Yes, sir. No signs of.
What are the signs you look for?
Signs as in on percussion, if there is any dullness.
Yes, anything?
Sir?
Diminished or absent breath sounds, shifting dullness, absence.
Yes, sir.
Have you heard of reduced vocal fremitus? Read Hutchison. Just read Hutchison. Okay. There's something called reduced tactile vocal fremitus. These are the signs of pleural effusion on physical examination.
Okay, sir.
Because pleural effusion is the most common secondaries of the breast rather than the cough with hemotepsis. Why?
Okay. Why pleural effusion is more common than cough with hemoptysis?
Pleural cavity is more affected because of the lymphatic drainage. It goes secondaries into the pleural cavity.
Okay, sir.
Okay, when there is predominant blood spread only, it goes into the lung parenchyma where you get cough with hemoptysis.
Okay,
that's why when I said when you ask for no history of suggestive metastasis, difficulty in breathing first, then only cough with hemoptysis. Okay.
Okay, sir.
Now we understood. Sir. Okay.
Yes, sir.
Examination, you have written no bone pain.
Yes, ma'am. I meant if there's any involvement.
You are under examination, no? The history is over. And your PR,
No, I meant tenderness. Any bone I should have mentioned is bone tenderness.
That you have written no paraspinous tenderness, no?
No, ma'am. I meant like long bones, like the femur or the humerus. For any bone myths. Paraspinal tenderness I'd written only for the vertebra.
Okay. And your PR, PV should come under abdomen examination. Then spine, then only you have to tell about the CNS. Spine is also part of your abdomen examination.
Yes, ma'am.
And anything else you look for in the abdomen apart from hepatosplenomegaly and ascites?
Sister Joseph nodules, umbilical nodule, or if you can palpate any ovarian mass, any pelvic mass to look for Krickenberg's tumor.
That should also be written that, no?
Yes.
No, there are no mass palpable.
Yes, ma'am.
How breast malignancy will spread to the liver, madam?
How? So one, it could either spread through hematogenous route, or it could. I've forgotten the name, but
And what are the
Yes, sir. It could spreads through there's a theory it spreads through the membrane into the liver. I've forgotten the name, sir.
There is one diagram in the DAS, clinical DAS. It shows how it enters the liver.
Yes, sir. Transcelomic spread, sir.
Transcelomic spread. But some examiner may agree or may not agree with this.
Yes, sir. Okay.
Tarini, you mentioned humerus femur. How common are metastasis to humerus and femur? Which is the other bone after lumbar vertebrae, which other bones which can show metastasis?
Skull, ma'am.
More common. Yes, skull happens. Yes, it's essentially the flat bone, right? Yeah, the iliac, the ribs, the iliac. Yeah. So humerus and femur, I have never seen in 30 years of my whatever. Unlikely, very unlikely.
Okay.
Yeah.
Okay. Okay.
I think you can proceed. Continue.
Okay. Okay. To summarize the case, it's a 53-year-old postmenopausal female with painless progressive lump in the right breast for the last 6 months with history of breast carcinoma in mother. On examination, a 6 cross 5 centimeter lump in the right upper outer quadrant, which is hard in consistency and has no fixity to underlying muscle, chest wall, or skin. And 1 2 cross 1 centimeter mobile firm central lymph node in the right axilla. Should I move on to the differential diagnosis?
Yes. Tell your diagnosis.
My provisional diagnosis is that it's a right-sided carcinoma of breast in a postmenopausal female with TNM staging of CT3N1M0 and of stage 3A, ma'am.
Dharini, if you mention the word carcinoma in your clinical diagnosis, a lot of examiners are going to get upset. You're not a pathologist, right?
Yes.
So you will never ever mention any pathological diagnosis in your clinical summary.
Okay.
So you'll never call it carcinoma. You can call it cancer, you can call it neoplasm, you can call it malignancy, but never carcinoma, right?
Oh, yes, ma'am. Okay.
Yeah, go
on. That's the end of my presentation.
Tell us now how you'll proceed.
So first we do the triple assessment. So I've taken history. We can proceed with radiological investigation and then histopathological investigation. So radiological investigation, since it's a 53-year-old female, I would proceed with the X-ray mammogram.
Okay, I also have this a problem with calling our patients females. You either call them a patient or you call them a lady, right?
Okay. Yes, sir.
Yeah.
Since it's a 53-year-old patient, I would proceed with the mammogram, X-ray mammogram, with the USG of the axilla. And then for histopathological investigation, I would proceed with the true-cut.
Breast? You want to USG of the breast, only the axilla?
Ma'am, the breast we're already doing a mammogram, X-ray mammogram.
Oh, that is X-ray mammogram, no?
You want the sonomammogram, ma'am? Combine USG.
Breast, which will give a clear ideas.
Okay.
What do you want to see in the mammogram?
Mammogram, I'd like to see if there's any clinically impalpable lump which has been picked up, either in the same breast or in the other breast, and if there are any signs of calcification or altered architecture. And
which type of calcification? Which type of calcification?
Speckled calcification, sir.
Speculated mass or microcalcification?
Yes, sir.
Okay. There's a definitive pleomorphic clustered microcalcification.
Pleomorphic, yes, sir. microcalcification.
See, that is visible mass. Why do you want to do a sonomammography in this patient at 53 years old?
I don't want to do a sonomammography. I want an X-ray mammography to see for any other lumps, any other clinically impalpable lumps.
Doing only X-ray mammography, not sonomammography.
You said sono.
No, sir,
Sir,
I said X-ray
I would
mammography.
disagree on this point.
Yes,
Indian women, even in the age in the 50s, still have denser breasts than
yes,
their
madam.
Western counterparts. So, and Dharini, when somebody asks you a question, you don't have to retract. You have to give an explanation, right? So the reason we still will always do it is because women still tend to have denser breasts in the fifth decade. And so it's part of the protocol of that's been laid down. So you would do a sonomammo, meaning a sonography of the breast and axilla, and a mammography of the breast and axilla, right?
Okay, ma'am. Okay.
And other things. And I think we'll get another set of mnemonics on what to see on a mammography very soon. So yeah, go on.
So
then I proceed. Yes, sir.
The mother had carcinoma. Now she is having. Will you do a screening mammography for the child, for the daughter?
Yes, sir.
What age?
So since it's family history, I think we have to do immediately, and then depending upon the mammogram results, we can either if she has a lump already.
At what age mammogram should start? At what age you should start doing screening mammography?
Ma'am, at 40 years of age.
Yeah, that's again a controversy. American trials say 30, but Indian trials say 40, 40. Okay.
So now they have made it 30 years.
30 years,
in the Indian subpopulation, because we are seeing a lot of TNBCs happening in their 30s. So the protocols are being changed in the Indian subpopulation to this thing include 30 years. If any high risk, then even earlier, like 25 they start.
Okay.
But I think those protocols will come into being in the next couple of years.
Thank you, madam.
Yeah.
Okay. Okay, you're done a mammography. What is the next thing? You find all the.
Yes, so I'd like to do a true cut biopsy for the breast lump and an FNAC for the axillary nodes, sir.
Have you done a true cut biopsy?
Yes, sir.
How do you do it?
So first I'll make sure that the area is aseptic, and after injecting local, I'd make a small incision over the breast, over the skin where I can find the lump. And I'll insert the true cut gun, and I will take around 6 core samples, sir.
What all will you look for it? No?
In the true cut biopsy, sir?
Yeah.
Yeah. So true cut biopsy will obviously find out what is the histopathological evidence. So then we'll look at ERPR status. ERPR HER2 status, and then we will also give the Nottingham scoring, which will tell us the nuclear pleomorphism, mitosis.
You start with whether it's invasive or
invasive or
number 2 is differentiation. Okay.
Differentiation.
Number 3, because poorly differentiated, moderately differentiated cannot be taken up for BCS. If it's an early case, I'm just telling. Number 3, you have to look for vascular invasion.
Yes, sir.
Then you look for the ERPR HER2 status.
HER2 status.
The process. Ajay Khanna is there. Ajay Khanna, sir, you want us?
What else would you look for, Dharini?
And then I'd look at the Nottingham gradient. It'll give us mitosis, nuclear pleomorphism.
What else? You would look for any component of DCIS.
Okay.
Yeah, because that will again change your what treatment you offer the patient, right? Okay. And the Chi index. I don't know if you mentioned that, but also the Chi index. It's a very Indian thing, but we do it routinely, and we kind of also base our therapy on that. So not so much an American or a European thing, but we do in Asia, we do mention the Chi index. Right?
Okay. Yes.
Yeah. Go on.
What do you understand by sonomammography?
No,
What is
Professor Ajay Khanna is asking. Dharani?
Yes, sir.
Ajay Khanna sir is asking question.
What
Yes,
is
sir. Yes, sir.
sonography? Are you able to
The
hear me?
sonography is, yes, sir, I'm able to hear you, sir. Is use of
Yeah.
ultrasound, USG mammography along with the X-ray mammogram, sir, distant mammogram.
No. When you say you are going to do a sonomammography, sono
Yes,
is
sir.
the ultrasound.
Yes, sir,
And
and mammogram is an
mammography is
X-ray.
X-ray. So you
X-ray,
are
yes,
doing
sir.
both? You are doing both?
Sir, I said I would get an X-ray mammography done, but ma'am suggested that you should get a sonomammography done. So
Sonomammography
I'm
is
not able to understand.
I
only
didn't say
ultrasound.
I didn't say sonomammography. I said you do a sonology, an ultrasound of the breast and axilla, and a mammography of the breast and axilla, both. So Dharini, don't put words in my mouth. And I gave you the reasons for that. So maybe that's how you should explain it to Dr. Khanna.
Madam,
So
I
I'll
think
know whether you
Okay,
got
I'm
it.
sorry, ma'am. I think I misunderstood. I think I misunderstood what you said. So the two separate investigations. You're saying it should augment it. Like I should get both investigations done.
It should augment each other. It should not
Yes,
be
ma'am.
either or. Yeah.
Yeah.
Now,
I
please
think
tell him
there's
why you're
there's a
doing it.
lot of confusion in the students that what is sonomammography. Sonomammography is only ultrasound. When you're doing
Okay,
it with
sir.
ultrasound, because we are doing it for the breast and it's a high resolution ultrasound is there. So sonomammography is only ultrasound. It is not mammography. Though we call it
Okay,
as a
sir.
sonomammography.
Sonomammography.
Yeah, so we call it as a sonomammography, but basically it is only ultrasound of the breast. Okay.
Okay, sir.
Yeah. So I
Okay.
think the
But
students must be
sir.
clear about that. Yeah. And then you are
So
saying that
it's-
cut
to
biopsy.
conclude, we have to do to both things.
No, it is
Yes,
not
sir.
both. It is only ultrasound.
Okay, sir. Okay, sir.
And why you are saying the true cut biopsy? True cut biopsy is a trade name. So what
Core
you
needle
should
biopsy.
say
Core
core
needle
needle
biopsy.
biopsy. Do not
Yes,
say
sir.
true
Core
cut
needle
needle
biopsy.
biopsy. Okay.
Okay, sir.
What is the diameter of a core needle which you use?
16 gauge needles, sir.
Okay, 14 to 16 gauge needle can be used.
14
And when you're
to
doing the FNAC, what is the gauge?
23 gauge needles, sir.
Yeah, 22, 23 gauge. Okay. Yeah, go ahead. Yeah.
Sorry, come to the end of my presentation.
Do you have the biopsy report or the sonomammography finding?
Yes, sir. So I have the biopsy report. It's given as the right breast is an invasive mammary carcinoma, no special type, with the Nottingham histological grade 3. And the IHC results are awaited, sir.
PR is awaited.
So
Yes,
can
sir,
we
it's
give her
awaited, sir.
can we give her a standard working IHC for her to take questions on? So if she's 53, so if she is triple positive,
Yes, ma'am.
how will you proceed?
Ma'am, since she's stage 3, it comes under locally advanced breast CA. So I'd like to proceed with neoadjuvant chemotherapy followed by surgery.
So what is the neoadjuvant you would do in a triple positive patient?
I'd like to give doxorubicin, cisplatin, and
Cisplatin.
yes, ma'am, and paclitaxel.
Nobody gives cisplatin, bacha. Triple positive.
Paclitaxel.
Triple positive means what?
Triple positive is luminal A, ma'am.
What is triple positive?
No.
Triple.
ER, PR,
and HER2 positive.
HER2 positive, yes, ma'am.
Right? So in a triple positive patient, what is your NACT?
I don't know, ma'am.
Would you like to give trastuzumab?
Yes, ma'am. Yes, ma'am. We have to give trastuzumab.
So
Yes, ma'am.
along with with trastuzumab, what else do you give?
Yes, ma'am.
You need to give
paclitaxel.
Yeah,
So
so you have to give a taxane
Okay.
with trastuzumab. And you can give
Trastuzumab.
pacli, you can give dosi, you can give whatever is your choice. You can give what is the frequency?
On paclitaxel, we have to give it weekly. With doxy, we can give it once in 3 weeks.
Right. And trastuzumab?
I'm not sure. I
So,
think it's
so trastuzumab also can be given weekly or 3 weekly. Okay, there's data coming in now which says that weekly trastuzumab with pacli works better in terms of the PR status compared to a 3-weekly trastuzumab. So of course the dosing is dependent on the weight of the patient, but you can give both weekly as well as tri-weekly, right? But you have to give it with a taxane. Okay. If this lady was triple negative, then you would like to add what you said.
Cisplatin.
You would like to add carboplat.
Okay.
In a younger patient, not in somebody above the age of 50, but in a younger patient, that would be the only other NACT that you would be giving in addition to this. Okay, after you finish this, what other NACT can you give?
Oh, since she's ER/PR positive, we can give her a selective estrogen receptor modulators.
No. What other chemotherapy can you give? What are the other chemotherapies you can use in breast cancer?
The regimens commonly used. That's what madam is asking.
What do you follow in your institution?
ECF regimen was
in your institution. What do you follow routinely?
The ECF regimen, sir.
ECF or CAF?
CAF regimen.
Don't confuse yourself.
Yes, sir.
One more thing which I would like all postgraduates to answer is, after getting all the investigation,
yes,
I would like to discuss the case in the tumor board.
Yeah. And I think she has to also mention the staging investigations. She didn't really mention that.
You have to do.
Yes,
you have
sir.
to do the
Yes,
staging. You have to look for metastatic workout, CT.
Yes, sir.
If it's LABC, definitely it is not X-ray. It is a CT. CT of the chest,
yes, sir.
CT of the abdomen.
HRCT. Yes,
So
sir. HRCT
all
of the
these
chest and
things
CCT of
with the IHC reports, before you decide, you said, I will discuss the case in the tumor board, sir. Then based on the tumor board, I will give you. So what the tumor board says, you can start. That will be a better answer.
Okay.
I think most of the examiners will agree, because these are the questions they won't ask you. Answer.
Absolutely. I think breast cancer is no longer a surgical domain. It has to be a multidisciplinary domain. I think soon surgeons are going to be out of work in breast cancer.
We are already out, madam.
Yeah. So yes, it has to be and so Dharani, it has to be like 3 things. Either it's taxane based, anthracycline based, and platin based, and then targeted therapy. So, and hormonal therapy. So all of them can be used as NACTs, or they can be used as adjuvants. But you must be aware of all of them. And a lot of us are not giving 5-FU nowadays, because it's not proven to be. So you give AC, or you give taxanes, or you can add carboplat, or you can trastuzumab, or goes one of the hormonal therapies. If it's a bad and anesthesia wise unfit patient, we can also add that, or for an ER/PR positive. So those are your NACTs. And for investigations, again, metastatic workup, you will have to do a CT brain, MRI brain. If it's a triple positive, you would have to do a CT, HRCT chest, you would have to do a chest, abdomen, you would have to do a bone scan. So I think the NCCN guidelines now mentions PET scan as an acceptable alternative. except for brain metastasis, where you do need to do an MRI. So, you could mention either or of those two things, but all of this should be the principles should be very clear for you. We become the cancer capital of the world in 2024. It's sad, and breast is heading the list. So you must be aware of all the possibilities that you can offer your patient, right?
Yes, ma'am. Yes, ma'am.
What is a tissue marker?
Sorry, ma'am. What is a tissue marker?
Tissue marker. You're giving neoadjuvant chemotherapy to the patient. Is there anything else that you would want to do at some point of time?
So as in, like, you can insert, there are techniques where you insert a clip or into the breast.
So what is the importance?
It reduces in size.
What is the importance?
Ma'am, if the size of the lump, if it becomes clinically impalpable after giving neoadjuvant chemotherapy, to know how much to excise.
Yeah.
When you are giving the neoadjuvant chemotherapy, how do you follow your patient?
So we have to see if there is a partial response, incomplete response, if it's stable or if it's progressing. So if it reduces to, if there's a 30% reduction.
When you are going to measure this response?
After each cycle, sir.
So after first cycle, you will measure that response?
No, sir, after each cycle.
How many cycles? Not after the first cycle.
After 3 cycles, sir.
At least 2 cycles.
At least
2 cycles. Okay. Then only you can measure the response of that.
Yes,
okay.
Sir.
And what is that response called as? What is the broad name for that response?
Criteria you are using. Sir is asking which criteria is being used.
RECIST criteria.
RECIST criteria, yes, sir. For solid organ tumors. Response to chemotherapy.
What is the expansion of RECIST?
I don't know the.
Please don't mug up the short SMS and comma. What is RECIST criteria?
Sir, I don't know the full form. It's just to measure the response to solid tumors. Response to chemotherapy.
Evaluation. Response evaluation criteria in solid tumors. Okay. That is that.
Yes, sir. Right. Yes, sir.
So is it only the clinical criteria or it is also the other criteria which has to be used? It is just the clinical one?
Yes, sir. Clinically, the size of the lump.
No, it is not only the clinical one. Okay, when you are going to tell about the RECIST criteria, you have to use your imaging modalities also for that. Okay, maybe your primary tumor is becoming less, but new lesions are coming up. Okay, so that is a progressive disease. Okay. Right.
Yes, sir.
And how long you are going to give the neoadjuvant chemotherapy? For how many cycles you are going to?
So usually it's given for 4 cycles, 4 to 6 cycles.
So how do you decide that?
Sir, I think it's individualized according to the patient. I'm not sure, sir.
Okay. The most important thing which you want to see is that whether the tumor which was inoperable before is becoming operable now or not.
Okay, sir.
Okay. So what does that mean? It is becoming operable now. What is the meaning of that?
As in, if you'll be able to give adequate margins, if it's responding or not.
Yes, it is responding. It is becoming smaller in size, and you can very well operate that patient. There is not fixation to the underlying structure is there. The lymph nodes which are there are not much matted there. The tumor has become smaller so that you can bring the skin flaps together if you're doing a mastectomy for that patient. So
Yes, sir.
But it varies upon the, some people they give only 3 cycles, some will give 6 cycles. But it is said that you should give the maximum number of the neoadjuvant chemotherapy as much as the patient can tolerate. So even to 6 to 9 cycles or even up to 12 cycles have been given for that. And then you decide upon that what is the response of that. Whether it is a complete regression is there or it's a partial one is there. What is the meaning of partial? What does that mean? If there's a partial one is there,
Partial response.
Yeah, what is that?
If there's at least 30%, if there's at least 30% reduction in size, it's called as partial reduction. So.
Right. So based on that, you decide upon your neoadjuvant treatment. And then you followed either by a breast conservation or you follow it with the mastectomy. Okay.
And I think you should know about the RECIST criteria here. I'm sorry, I was off for a bit, but I don't know whether that was mentioned. So Dharini should know about the RECIST criteria. And I think, the whole reason of giving upfront the entire thing and getting pathological remissions hasn't really now translated into overall survival benefits, so people, I mean, everything is all right, sandwich therapy, this, whatever is thing. So I think in breast, everybody keeps yo-yoing. Like 6 months back, they'll say that you should wait for PR. Now they say that sandwich therapy is okay. Then they say that it does. So you should have alternatives, and you should be able to justify whatever you're doing in terms of those alternatives. Right? I mean, when you become a consultant, you will have to, everybody will have different methodologies of treatment. You have to be able to justify why you're using a particular kind of treatment. Right? For that, you need to know the statistics.
Okay.
So what is the plan for your patient?
So we're awaiting the IHC markers. And after discussing the tumor board, we'll mostly proceed with the neoadjuvant chemotherapy and followed by modified radical mastectomy.
After that, after the MRM, what next?
We have to see if all the margins are clear, sir.
Yeah.
If not, then we might have to proceed with radiotherapy. And after that, we'll have to keep the patient under surveillance.
So radiotherapy is only for the positive marker? The radiotherapy is only given for the positive marker?
No, if she has positive margins, something so.
You have done
If you have positive margins, will you give radiotherapy? What will be your plan of action with positive margins? You should revise the margins.
Okay.
Your patient is, you just mentioned, what is the staging of your patient?
Stage 3A, ma'am.
It's an LA.
It's LABC. It's LABC.
It's an LABC. So would not all LABCs need to have radiation?
What is the indication? In other words, what is the indication for radiotherapy?
Positive margins.
No. Dr. Chopra just told you, positive margins is not an acceptable surgical outcome. You have to go in and excise all the positive margins. So that is not an outcome. It depends on the stage of the stage of the disease in the breast and the stage of the disease in the axilla. So what kind of
stage 3 and stage 4?
So would your lady have? She's falling into the LABC category. Would she, by whatever default, require radiation or not?
Yes, ma'am. All LABCs will require radiation.
Yes, all LABCs require radiation. Then when you're coming to the axilla, how many axillary nodes warrant radiation?
N2 and more than 4 nodes.
Yeah. So you have to be very clear. So triple negative, LABCs, axilla as mentioned, So all these are high risk factors. So there are standard indications, and of course, all patients, if you have not done an MRM and you've done a breast conservation, then irrespective of the staging, the patient will need radiation, right?
Yes, ma'am.
And then what after radiation?
After radiation, ma'am, we'll keep the patient on surveillance.
No, till your IHC comes, let's talk about a triple positive patient. What will you do for her? Post-menopausal lady, triple positive.
We can give a selective estrogen after when we do surgery. We give a neoadjuvant chemotherapy, then surgery, followed by radiotherapy. After this, we'll keep her on surveillance.
You can start it with the radiotherapy. Along with the radiotherapy, what else will you start on her?
I'm not sure. Hormonotherapy.
What are aromatase inhibitors?
Yes, ma'am. We give her aromatase. Since it's postmenopausal, we'll give her aromatase inhibitors.
And if she was pre?
We'll give her some selective estrogen receptor modulators.
You give her what?
Selective estrogen receptor modulators, ma'am. Tamoxifen. If she was premenopausal, since she's postmenopausal.
So she's postmenopausal. So you would give her an AI.
Letrozole.
Yeah, and
yes, ma'am.
Since she's also HER2 positive, what else would you do?
We'll give a trastuzumab.
For how many cycles?
I'm not sure.
12 to 15 cycles over a year. Yeah.
Okay.
So we need to complete that whole story. What is the side effect of letrozole? What else will you add?
Ma'am, when you're giving we are scared of
so she can get osteoporosis, right? Very significant osteoporosis.
Yeah.
Have you heard of bisphosphonates? What is their role in ER/PR patients? Positive?
Yes, she might have osteoporosis. For that, we can give her bisphosphonates.
No. That's not why we give bisphosphonates. What does bisphosphonate do?
It will help in if there's increased calcium resorption. If there is increased calcium resorption, it will.
No, it is shown to make the bones more impervious to metastasis. Okay. So that's why you give. If she is osteoporotic, you would give her vitamin D and calcium and what have you. But bisphosphonates has been shown to make the ER/PR positive patients bones resistant to metastasis. Okay, so you can give it like zoledronic acid or oral osteophos or what have you, 3 monthly while she's on this thing. So oral bisphosphonates are good when she's on follow-up, right? And when would you start screening her? When would you call her back after all of this is done? How often would you screen her after all of it?
For the first 1 year, we'll call her every 3 months. And after that, 6 months, 3 months. And after that, we'll call her yearly once.
I think I'm done with the questions. I'm sure if whoever else wants to ask questions in summary, please go ahead.
Any role of reconstruction?
Ma'am?
Any role of reconstruction?
If the patient is willing for
all ladies must be given an option of reconstruction. And should be given the pros and cons of immediate and delayed reconstruction. And so read a little bit about what volume replacement by either flaps or by implants, both.
Can we give this patient an option of immediate reconstruction, ma'am?
All patients should be. I think we can, others can also opine, but all patients should be given an option of reconstruction.
Absolutely. And I think it's not just cosmesis. it also causes, I think, a lot of spinal, even spinal disorders, I think, have been shown because of the mismatch on this thing. This lady, yes, Dharini, you can give her upfront because if she was, she's a good disease. If it's triple negative, I'll wait. I won't do an immediate reconstruction, but if it's ERPR positive, you could do a upfront reconstruction in terms of a flap or a implant.
Okay, ma'am.
Yeah, many of the patients, they require both chemotherapy and hormonal treatment. So which one you will finish first?
Chemotherapy, sir.
Why?
So hormonal therapy, usually drugs like letrozole or tamoxifen, tamoxifen, we usually give it for 5 years. Chemotherapy is usually 4 cycles before neoadjuvant is given as 4 to 5 cycles. But tablets like tamoxifen are taken over a period of 5 years.
So why don't you start simultaneously chemotherapy and the hormonals? Let us give the patient the chemo, and also along with that, we give the patient tamoxifen. If you are thinking because of that, then we can give it simultaneously. Okay, it depends on the cell cycle. Okay, you have to understand the cell cycle. Because tamoxifen is going to push all the cells into the Z0 phase.
Okay.
While if they go into the Z0 phase, the chemotherapy cannot act because they are not proliferating. So that is why you have to always finish the chemotherapy first, because the cells are in the Z1, G2, where they're actively proliferating. But if they go to the Z0, then the chemotherapy will not act. So that is why always you finish first the chemotherapy, and then later on give the patient the hormonal treatment. Okay?
Okay, sir. Yes, sir.
Dharni Priya, how tamoxifen will act and how aromatase inhibitor will act?
Tamoxifen is a selective estrogen receptor modulator. So wherever the estrogen receptor is, even if it's in the uterus, it'll increase or it will decrease the effect. As in, if it's in the breast, it will decrease the effect of estrogen receptor, the sensitivity. Whereas an anastrozole is an
It blocks the estrogen receptor
in the breast.
and
Yes, sir.
aromatase inhibitor.
But in the uterus, it will stop the conversion, sir. Aromatase, it causes the conversion to estrogen. As in,
prevent peripheral
conversion. Yes, sir.
Okay. Proceed.
Very well presented. And I like the energy levels with which you've been responding.
Yeah, I agree completely. She's read up. She's read well. She's done her bit towards her presentation. I enjoyed the conversation. So Dharini, well done. But there's still so much more that needs to be traveled on the road. So all the very best.
Thank you so much, ma'am.
Dharini, do you have any questions to ask the faculty here? Any doubts or any clarifications?
I just have one doubt, sir. I thought for sentinel node biopsy is only done in case of clinically impalpable nodes. But can it can it also be done if a central or a posterior node is involved, and if the anterior node, which is the anterior group, which is the first to be involved, if it's not involved, and if in my case, if the central or lateral node is involved, is it still necessary to do sentinel node biopsy?
No, so we mentioned that your patient would be a contraindication for doing a sentinel node biopsy.
Or sentinel node biopsy.
Yeah.
Okay.
And so sentinel node, not necessarily, see, a lot of times after giving chemo, they all become negative. And, so now there is more, but I think on an MS level, if a node is palpable, I think it's fair to say that you go in and do a formal axillary dissection. I think on an MS level, that would be accepted if it's a palpable node, irrespective. Right?
Okay. Okay, ma'am. That's all. Thank you, ma'am.
Any other questions or comments from the faculty, madam, sir?
No, sir.
Thank you, Dr. Anni. Thank you all the invited faculty and our own faculty.
Thank you, sir.
Rishi
Thank
sir,
you, sir.
Karnakaran sir, and Madam Ratna ma'am, Babita ma'am, and Shilpa ma'am. Thank you for joining. And we look forward for another week of single case thing. Then we amongst our faculty and the students will restart the situation. Then consider to continue this way or continue in 2 ways. Good luck to you and thank you for joining this evening. Good night, everyone.
Thank you, sir.
Good night.